like I was told 20-something years ago I needed a fusion, and I was like, I will cross that bridge when I get there. Knock on wood, and I know my spine is more set up for problems, but because lucky I married a CVP chiropractor, and I practice what I preach. Like, if I can put a surgery off 5 years, 10 years, 30 years, that is a huge win.
Hey, Dr. Chris Gubbels, and today we are here with Dr. Evan Katz on the Health Heroes podcast. Evan, thanks for being on the show.
Thanks for having me, man.
This is a great show because it's someone that is both a colleague, someone that has mentored me, and someone has been an instructor through part of my education in my chiropractic career. And so, first of all, Evan, talk a little bit about yourself. And I'm curious because I've never heard your story. I'm curious, how did you, ever get into chiropractic? And then how, going down in your chiropractic career, how did you get into what we do now in chiropractic physics and specializing in true corrective chiropractic?
Yeah. It's funny, for as long as we've known each other, you don't know.
I don't know how you got into chiropractic.
Yeah, huh. All right, so growing up in New York, my uncle Jerry, my mom's brother, he's like 80-something years old, and now he still practices. So I used to go to a chiropractor when I was a kid, and it just made me feel better. I never really questioned it to be like, what is it doing? And then
the person that you went to is still in practice.
Yeah, it's my uncle. He's he's been practicing, I think, for 60-something years. Yeah, it's my mom's brother, and he's in New York, Jerry Whitner. I used to go, and it made me feel better. And then throughout my life, as I got older and moved away, I ended up hurting myself, which I think is the same story you hear a lot of chiropractors. Mm-hmm. Medical doctors are like, this is the way you're going to be, or here's drugs and surgery, and then a chiropractor helps, right? So a chiropractor, they helped me, and then I've had other bad things happen in my spine where I've needed more interventions, but chiropractic has always kind of kept me going. Mm-hmm. So I looked at all the different, I knew I wanted to do something in healthcare because I was always drawn to anatomy and physiology. And this was I graduated high school in '91, and that's when HMOs and PPOs were coming in. Mm-hmm. So I started looking at, the medical profession, and back then,
that's where they came in.
It was right around there. Yeah.
So what was it before then?
It wasn't like managed care.
It was just that's what they called the Mercedes 80s.
It was
providers would just bill, and then you get a check.
Yeah.
Okay.
But this was also before the internet, where when people were like, "Oh, you should go and be a doctor," really all I knew about was a primary care, maybe as a surgeon. But now, you're like, oh, there's pain management docs, there's subspecialties, which I didn't know was even available or an option. So I interviewed a bunch of medical doctors, and they all talked me out of it. They all seemed miserable. They didn't like their jobs. At that time, I looked at dentistry, but never had good teeth. And I was like, I don't want to work on just one body part for the rest of my life. And then I interviewed physical therapists, and I interviewed chiropractors, and they all seemed really happy with their decision. So I thought about going to physical therapy. My uncle was like, chiropractors have more education than PT, and you could do everything a PT does and more. And then at the school that I went to, I could also take I can get licensed to do PT as well. Yep. So I decided, I was like, I could do both, as opposed to just PT. So that was the route that I went. And then the second part of that question, how to get into CBP.
So you went to Life West, right?
I went to Life West,
so all the way across the country.
Yep.
What got you there when you were in New York?
Well, so I was in New York, and then I moved out to Colorado after high school to ski. And then I went to school here, and then I didn't want to go back to the East Coast. Not that I have anything against it, I just like the mountains and stuff.
And wet.
Yeah, and wet and bone chilling. I like the Colorado West. So I looked at the schools, and I liked Life West just for, it seemed like they offered a lot more, like they had more availability and more, and also at the time, the professors that were there, the instructors, had some really good instructors. So I was like, all right, I'll go out to Life West, knowing that I was just gonna come back to Colorado. But when I was in school, this might be somewhat controversial, but I remember, you'd get, as you're going along the program, you're like, okay, you're adjusting. And they're like, okay, here's this person's spine, and this is what they're gonna be. And I was like, well, if we adjust it,
that's their listing.
But yeah, I didn't want to talk about that. Yeah, here's what they are. Here's this, and here's a subluxation. Yeah, and
that'd be great if you just adjusted the same thing and to think about it your whole life. Would have been like, oh yeah, you're C1, you're on the right.
On the right, and then I was like, well, so we can't fix it? I was like, if you keep adjusting them and that's how their subluxation pattern is, like, how come we're not fixing it? And I remember asking those questions. I was like, so that's a problem. Can it be fixed? Oh, and you get these interesting, oh, if your body wants it fixed. And then I'm like, well, wouldn't that also be true for the subluxation? So if that's true, why are we needed? I don't understand this. So my buddy, Dr. Philip Aragon, who is in Arizona now, he was taking CBP elective because Life West had it, and that's when Don Harrison was still coming in.
So Don was coming in when you were there?
Yeah, when I was there. So I remember, and I tell this story, I don't even know if this guy is still around, but my first CBP, I don't want to call it a conference because we had it at school, like elective, my buddy Philip was like, let's go, like, come, you got to take a look at this, it's really cool. So I went, and the doc that was there, he was from San Francisco. I don't know if he's still there. His name is Dr. Michael Gadzar. It's the only time I've ever talked to him, but I remember he was presenting to us all, and we were students, and I'm sitting there, and he's talking about this cheerleader, and she had chronic pain. She saw all these different chiropractors and this and that, and he's like, and then she came in her cheerleading outfit, and she had these like diamonds cut out in it, and the diamond was, they could see her episternal notch and her belly button. And he's like, and it was translated. And he's like, and then I took the x-ray, and then he's like, we did this, and then he showed the pre and post. And I was like, it can be fixed. And he's like, yeah, we fix it all the time. And I was like, that's the missing link. And then I was like, that now it makes sense. Because then when I would talk to Don Harrison, or those guys that were teaching at the time, they would show pre and post imaging. And I was like, okay, so C5, where the kyphosis is no longer a PRS. You could change it. So the quote unquote listing, and I was like, this is exactly what I want to do. This makes sense to me. And then that was it.
Yeah.
Yeah.
Cool. And then you end up coming back to Boulder.
Yep.
And how long have you been practicing here in Boulder?
Man, it's gonna be 25 years in October. I know.
It goes fast.
It goes fast, yeah. And now when I say that, like, I don't know how long you've been practicing, I'm like, oh, 25 years, like that, like, yeah, man, I'm getting old. You know, like, yeah, it's interesting.
It's a journey. And so, talk about, like, people out there a lot of times throw out this word, corrective chiropractic, and I think patients say that too, and I think patients really want that when they understand what it is. But like, we always talk about, like, what does that actually mean, right? Does it mean you're going to get adjusted your whole life? Is it getting, you're doing intensive adjustments for a period of time? Or, like, when you think about corrective chiropractic, what does that mean to you?
Yeah, I mean, I think, as you and I have talked many times about this.
And maybe talk for a patient that is like, I want to be fixed to whatever degree.
Right.
Kind of help define in, like, that context too.
Yeah, and I think that's the complicated or the confusing aspect of chiropractic, right? And the somewhat polarizing within our own profession is, what is corrective care? For me, is if you truly find spinal subluxation, in my world is spinal subluxation, you could objectively show it, measure it, it correlates to the physical exam and their findings, and it's outside the established normal ranges. So we see that on x-ray, DMX, even MRI, findings that, just like if we take your blood pressure.
Yep.
I can't say you have high blood pressure unless we take it. Same is true with the spine. I can't say that vertebra is out of place.
You just can't telepathically,
like
or,
look at you
over the phone. You couldn't
totally
tell me where what's
like
wrong.
C4 is pushed to the right, and as much as we're joking, and as much as we're joking, that
people do
we
that.
see that, right? And so for me, is we really analyze both the structure and both the sagittal and coronal planes, so from the side to the front, as well as intersegmental movement, right? Looking at, like, on DMX or starting with flexion extension, and then if it's outside the range that's causing abnormal physiological load and issues, corrective care to me is correcting those sagittal, coronal, and stability issues. To me.
Yeah, I mean, we see similar things in the scoliosis world where people come in, and if we talk about correction, or maybe reduction is a better word, because we know there's things that we can't change.
Right.
And then we have to know what the goal is, and there a lot of times are areas that can be improved, but also it's knowing, like, what is, like, in the physical world, like, what can and can't be changed, and also what should you attempt to change and not change as well.
Well, and I think exactly that, but also, even if, like, in your world, where you specialize in scoliosis, is the important thing is, if you can't change it, can you prevent it from getting worse? And I think that's a corrective care too. And
Yep.
as much as I want to say just adjusting is great and it has its own benefit, but there's no evidence that it's going to fix the structure. And then that's what we do in our office and aspects of what you do in your office to really change the
natural history of where this would go.
Where this would go, right.
You familiar with Dr. Peter Attia? And he has the
No.
book called Outlive.
Oh, yes.
Yeah.
Yep.
And I'm reading his book, and I'm like, man, you like think like a chiropractor
Totally.
that does chiropractic
Yes.
biophysics.
Yep.
And I know you also you work with a lot of healthcare professionals. I know you get direct referrals from other spine specialists and surgeons. And when we were really reaching out and educating other providers on scoliosis, I learned like the surgeons would get that. Like sometimes they would say, okay, don't tell me you're going to straighten the spine. I'm like, no, there are things we know we're not trying and we can't attempt, but we could look at patients and look at how they had regressed. And I would ask them, I said, if we did nothing, like where is this person going to be in 10 or 15 years? And if we could even show like we improved their function, their ADLs, and then we kept them at a certain level,
right.
Even like that is a huge success sometimes.
Huge. And I think that's the thing, like we don't have a special language in chiropractic. We don't own it. Everyone knows, and that's the beauty, but also the frustration within our own profession is our own profession has their own language, but I'm like, okay, if you say it's a subluxation, you're really saying that it's an abnormality of the spine leading to physiological changes. But every spine profession looks at that too. So how do you communicate with them? And I feel like that's where in chiropractic we lose is like, okay, define what a subluxation is, define what your adjustment is, and why is that a problem? And in ours is like, you know, you're talking about scoliosis, you're talking about abnormal coronal alignment. Well, guess what the spine surgeons I work with scoliosis, guess what they look at too? Scoliosis. They understand that it's outside the norm. And look, the surgeons that I work with, a lot of them are really great where they will tell me like, do not send me a patient unless they have severe neurological compression or a brain bleed or a tumor or something like that. And if they have severe neurological compression, I'll decompress it. But they're at the point now, they're like, yeah, you have axial back pain. And guess what's gonna happen if I fuse you with axial back pain? You're gonna have more axial back pain.
Yep.
And the surgeon's like, and then that person's gonna hate me. So treat them the best you can. And unfortunately, even as myself have dealt with chronic pain, like we all want that magic bullet where it's gonna go away. But the areas could be a little bit weaker. And how do we manage this to prevent it from breaking down? And if you can hold someone, you know, like I was told 20-something years ago I needed a fusion, and I was like, I will cross that bridge when I get there. Knock on wood, like, and I know my spine is, you know, more set up for problems, but because, you know, lucky I married a CVP chiropractor, and I practice what I preach, like, if I can put a surgery off 5 years, 10 years, 30 years, that is a huge win, right? So, yeah.
Yeah. Now another thing that you do different or something that's unique about your practice is you're involved in a lot of research. And I think in chiropractic we always talk about the spine and how it impacts physiology, but you've had some things that have actually demonstrated that. So one paper I think of right away is your cervical kyphosis and talking about blood circulation and the correlation with that. So at a high level, can you talk about kind of what that study showed and like what that means? That's a great paper that actually shows how it impacts not only your physiology, but potential long-term health and quality of life.
Yeah, I've always been drawn to research because it kind of gives us clues and it just makes us change our thought process. So with us, we were getting a lot of patients that would come in, just like your patients, with abnormal curves, and they would describe what sounded to me as a jiu-jitsu guy, it sounded like a blood choke, right? And if you get like someone puts a really good blood choke on you, it doesn't hurt, and the next thing you know, your vision starts to go until you're out. And I was like, wow, that sounds like a blood choke, you know? So there are studies before ours that talk about abnormal cervical curves decreasing hemodynamics or blood flow on ultrasound. And there's a lot of studies now that even talk about kyphosis in Journal of Neurosurgery. There was a huge one that came out called looking at the state-of-the-art abnormal cervical curves and how the abnormal curve can even decrease microvasculature to the spinal cord and so on. So we looked at it, we're like, oh, well, just look at it from a very simple, hydrodynamics, if I have a hose and it's in my yard with like a slight curve, everything's flowing out. But if I kink it, what happens?
Yeah.
The pressure increases, but there's more turbulence, and then the amount coming out decreases, right?
Mm-hmm.
Because it's, so then the fly fisherman, as you and I, have fished together before, I was like, all right, well, if you have a stream and there's this nice bend, no problem. But all of a sudden, if you put a kink in, what happens?
Yep.
It gets pooled up, then it gets, so I was like, all right. So with that, I was like, okay, well, what happens above that kink, which is the brain?
Mm-hmm.
So my wife and I, we hired the MRI center here. We got the tech, and then we hired a PhD from CU to help us, and we took patients with abnormal neck curves that we saw on x-rays. We already knew they had it. We knew they had that altered cervical shape. And then I had to cut this traction device to fit the MRI, and we put him in the MRI. We did what's called MR angiograms. So we're looking at the blood flow. And then without them getting off the table, we put their neck into a normal curve. Now,
so you basically did an MRI with them laying
an MR angiogram
in their state how they were,
Yep.
and you could measure like the blood flow and everything.
So what we did is we did what's called pixel intensity. So we were able to measure objectively, meaning it wasn't like you or I looked at the picture and be like, that looks like less.
Yep.
We were able to do pixel intensity, and then it was able to determine how much blood flow on the angiogram was there in that same slice on that same area.
And then so without moving them, you put them in there under a traction device that reshaped the normal cervical curve in their spine, and then you redid the same study.
Right.
You did a comparison.
And then we did a comparison. So it's funny because I've been to conferences where they're talking about the paper, which is great, and they're like, oh, this shows that increase in the cervical curve increases blood flow to the brain. And I'm like, no. And I was at one conference, and the guy, he didn't know I was the author on the paper. He's like, well, that's what the paper is. I'm like, I actually authored that paper. And what I think it says is, I don't think that's what it says. Like, oh, an increase curve increases blood flow to the brain. I'm like, no, man, that's normal blood flow. It's a cervical kyphosis decreases blood flow. That's just getting it back to normal.
It's restoring it to normal.
Right. As opposed to, because they were like, oh, I'm like, no, we're not increasing blood flow. It's the abnormal sagittal alignment decreases it. We're getting it back to normal. Yeah. So we did that, and we looked, and then we had, it's funny. It's gotten, it's been referenced a bunch. It just got referenced in this really awesome vascular paper. The only people that had a problem with it was chiropractors. And we had some like, oh, that's because you put their head back. And I'm like, have you ever been in an MRI machine? I'm like, their head can't go back. Their hard palate was in the exact same spot. They're like, well, their blood flow would go up if they hung their head over a stair. I'm like, well, yeah, because their head is now a foot under their body or below their body. I'm like, that can't happen. And we made sure that didn't happen. So I don't know why,
Well, yeah, and it was, if anyone looks into some of the neurodegenerative conditions, you look at things like Alzheimer's and things in that realm, one of the things they really look at is, like one of the reasons like exercise is considered one of the biggest preventative things you can do because it increases circulation.
Right.
And so they're tied to circular, or if you lose your normal circulation, there is a lot of evidence that shows that could correlate with potentially developing a neurodegenerative disease.
Yeah, and we actually talk about that in the paper too, how one of the largest thought processes on dementia is what they call decreased cerebellar hypoxia. So they're like decreased blood flow to the brain.
Hypoxia is like, that's a lack of oxygen.
A lack of oxygen, right? And they're saying from decreased blood flow. And we always joke, I was like, if this paper was a drug that actually increased sagittal alignment, got better blood flow to the brain, we'd be talking about that. I'd be like flying a helicopter somewhere. Yeah, right. But no one cares because you can't publicly trade that type of treatment, in my opinion, right? If that was a drug that was like, hey, one of the biggest aspects of dementia is decreased blood flow to the brain. We have a drug here that increases blood flow to the brain up to, we found 220% with no side effects, with the exception of it also increases the cervical curve. It'd be, and I'm not, sour about that. It's just it's super hysterical.
It's the same thing, and you look at a lot of things in healthcare. It's where you look at, I think, things in regenerative medicine. I think it's where a lot of natural things are never really brought up in healthcare.
No.
You look at even like, you look at like just COVID, looking at your vitamin D levels and stuff, because you can't patent those things that are natural. I think that's where a lot of, I think, negative things come from.
Oh yeah, I mean, look, 90-something% of the largest, outside of the last, end of care life, but diabetes, heart disease, all that stuff could be eradicated with lifestyle. There's no drug,
Yeah.
right? But what do you get if you go to most doctors with high blood pressure? You don't get a workout routine. You don't get even, they might mention it like, hey, you should try some exercise, but here's this drug, right? It's not, it's kind of bizarre.
Yeah. Now, another thing you guys actually have a niche in is just traumatic injuries.
Yeah.
And that's something where I think if you look, you can find people that are really good at doing manual adjustments, which on its own is a science and art. But the number of people that come in to see me at Scolio Care that I want to recommend chiropractic that have had a negative chiropractic experience, or they're wary about going to chiropractic, sometimes those experiences are earned. So can you talk about just like, one, if someone actually has a traumatic injury, like how important that is to find someone that's not only skilled in the healing, but just being able to properly evaluate to understand what someone is dealing with, and then some of the things that you guys do that are very unique with traumatic injuries.
Yeah, so we see a lot of patients with traumas, whether it's car crashes, and we've lost several years of our lives publishing papers on looking at that. Like some of them were years long. And I can't speak for every practice. We just talk about my wife and ours, where I think when someone comes in with a problem, because I've been a patient, we really take time, right? We're not one of these chiropractors that, as you and I know in our profession, will, how many patient visits are you seeing a week? Like that's a brag thing. Mm-hmm. To us, I look at sometimes the higher the number, I'm like, you're not doing a good job, right? Mm-hmm. Because you need to slow down, and not everyone who has pain might have pain for a different reason, right? It could just be a simple sprain strain. It could be a cervical kyphosis. It could be pain due to scoliosis where the facet joint is completely degenerative and they're getting lateral listhesis. All those things, in my opinion, should relate to different how we treat those people. So a lot of these patients we see, and the same, not to throw my own profession under the bus, same is true when they go to medical doctor. You have pain, here's a prescription, here's this. And I think in our profession, in our practice, my wife and ours is, it's not a one size fits all. We take our time, we listen, we try to analyze, we try to look at, and then we try to take the time where we have patients that come in and sometimes I'm like, look, I can't touch you until we find out exactly what's wrong. And that could be the frustrating part for them, is like, look, we need to do another test. I need to see something else because I may treat you differently, or I may not be the person that's going to treat this. To really slow down to gather enough information to see what's happening, as opposed to, setting up shop at a fair and adjusting people right there without knowing their history or what their spine looks like, or hearing what's happening with them. So I think with trauma, especially when they're hurt, is analyze them. Start with a static x-ray if need be, a digital motion x-ray to see the mechanics, not just at the end range, but the mid phase. Like sometimes we see the joint slip backwards and we're like, oh, maybe we need to traction it or adjust it this way. Or we see it slip forwards, like we're not gonna do that because of this. Is adding those things, and we think in our practice, that's why I think our practice is busy, and we've, by slowing down and trying to get patients better, as opposed to like, hey, lay down, we're just going to adjust you and your body's going to take care of the rest.
Yeah, I mean, kind of how you run your practice is really similar to how I run Scolio Care, and it's like, in my other practice, we were getting busier in scoliosis, and I realized like I could not do that kind of work while I was doing everything else.
Yeah, right.
You can be busy, but I knew it took a lot of attention and focused type of care, which is like a Scolio Care. It's like, it's different. It's a boutique. And, and I think the kind of care I know you do, and we've talked about this even throughout the years, like people come to see me and they've been to like Children's Hospital, other places, and they're wondering like why like this, they see it's very different and very unique. And I'm like, look, those places are busy and they definitely serve people and they solve some big problems. But like, big and complicated problems, they need people that can slow down and just do different level of care. So on that, patients watch this, people could be watching this. Can you talk about what is it like to be a patient in your guys' office with you and your wife working, and how that may be different than what someone's experienced in other places?
Yeah, and I think to touch on what you're saying is, why you use Scully care. Why do we treat these certain things as, I don't want to be, a jack of all trades and an expert at nothing.
Yep, we treat two things, kyphosis
Right.
and scoliosis, like that's
Right.
it. And there's plenty to do in that thing alone.
100%. And so what we do when patients come to our office is we do a consultation first. We usually do a complimentary consult to see if I can help them, right? See what type of images they have, gather the images. If they don't have it, we see what type of imaging we think is going to be necessary. A lot of times we could take the image here, and then a lot of times we send them for imaging that we don't have in our office. After we get that, we look at their images, analyze it, then we get them back in for an initial exam. After that initial exam, before we show the images, we like to do an exam to see what correlates to that image, right? So like if we see, let's say, we have a digital motion x-ray here. Let's say we happen to do a digital motion x-ray and we see instability in one direction. And then I don't want to tell them that first. I don't want to put anything in their head. Then we're like, all right, let's see. And then if we see that it all correlates, we're like, this is a problem. And then we go over the findings with them, and then we come up with a plan to try to improve and fix, just like what we were talking about in the beginning. Like, here's the true subluxation problem. Here's how this subluxation is causing your issues, your physiological issues. Now, what can we do to try to help it? Then we start, I tell patients all the time, I'm like, look, we're gonna start really slow, right? I was taught early on that it's always better to do too little than too much, right? Doing too much, even if it feels good, I don't know what it was that made you feel like that. And then if you flare up, managing that flare up is way worse than, hey doc, didn't really feel like you did much the first time. Great, let's start adding more in and see what you can do.
Yeah, you can always do more.
We could always do more. And then we start to put them through a full, true structural chiropractic with rehab we do in our office, and then we have them do things at home, right? It's the same thing. Like, I tell patients this all the time. Getting healthy is not easy, right? Being unhealthy is super easy. You make no time to get any type of care for yourself.
Yep.
You don't think about what you eat. You don't think about how you sit on the couch. You don't think about anything. There's no energy in it. Getting healthy or being healthy takes time, but getting healthy, like if an injury that occurs, to get back it's a lot. And if you come here and you're here in our office, say for an hour at a time, which is typical, there's still 23 hours left in the day to either help or not help what we're trying to accomplish. So we're gonna do this, we're gonna manage this. Here's some tools that I also need you to do when you're home. Even simple things like, sitting up straight, keeping your back moving when you're sitting, like things that like this, you have to start to implement this to keep pushing that ball uphill.
That's one of the things I had to learn early on is you got to get patients to own their health. You can't own it for them. You play a role in that, but they're responsible, and you're really there as almost like guide to give them the right instructions and tools, but it's ultimately they have to use it.
Yeah, and I think, that's another topic too that I've talked about with others, where they argue with me. I'm like, you have to educate your patient. None of this sales crap and if a patient is uneducated on their condition, they don't know what's wrong. If they don't know what's wrong, they don't know what position is better or worse for them. If they're not educated on their body and what's wrong and how it's improving, or how that problem that you told them they have can get better or can get worse, or how it affects their physiology, they don't know what to do when they leave. So we always, in our office too, one of the big, this is like, your spine has been studied. These findings have been studied. You should understand that too, right? The patient should know, like, oh, I have this condition. And I want, when patients leave my office, like I have patients come in from other offices, like, oh, I have, neck pain. I've been seeing this chiropractor 2 years. And one of the things I always ask, I'm like, and I say this, I'm like, I'm not questioning you and I'm not questioning your previous, but you've been treated for 2 years. Like, what's wrong? And they just look at me blank. And they're like, well, my neck is jacked.
Yeah.
I'm like, has anyone explained to you what does that mean? Like, because I want, when my patients leave, if someone says, what's wrong? Oh, I have a kyphosis at C4, and kyphosis can cause irritation of my cord and decrease blood flow, and we're trying to improve that. That's what I want my patients to be educated and informed about, as opposed to like, oh, your neck is subluxated. like, okay, well, can that subluxation be fixed? What type of subluxation is it? And yeah.
Yeah, we always teach in scoliosis, it's really important patients to understand what's causing it and why it's happening so they can understand how we're going to approach treating it.
Right.
In my other doc, I have a young associate, and I always tell them, like, look, yeah, they may have a problem that is their neck pain prevents them from doing whatever in their life, but they need to understand what's causing that. And they understand what's causing it and how you're addressing that, then they can make an educated and intelligent decision about whether or not they want to work with you to help them reach their goals.
Right, and they're not, if you're just like, hey, you have this problem, do this, and they're like, all right, and then they don't really understand it, and they go home, they're like, I'm not sure,
Someone just says, oh, you just tell me what to do. I'm like, no, it doesn't work like that, because that's only going to get so far.
Right. Yeah, I mean, and that's like, oh, you have high blood pressure, here's a pill.
Yep.
Right, like, you're not, that high blood pressure is not going to get corrected.
Absolutely.
Right? There's like, oh, they told me to take this. Like, why do I have high blood pressure? Oh, this is that cheesecake you're eating 3 times a day? Like, maybe we should start to look at that.
Yeah.
And the same with their spine. Like, why? Like, what do you do all day? Like, oh, I sit in my bed reading. And I'm like, okay, let's talk about that, right?
Yeah.
And giving tools like, hey, I still want you to read, but are there things that we could do to get you in a better position so we're not constantly loading? And that, I think that's the problem too that we see, where we have patients with massive kyphosis, and let's say even instability and flexion with their head down, and they've been seeing some PTs and they're giving them chin tucks and forward head stuff, and I'm like, this makes zero sense, right?
Yep.
So like, let's look at why you have a problem and why are we pushing you more into that problem, but they don't know, right? That the patient, I mean, they're like, this is what I was given, like, and then when they see their neck and we educate them on it, they're like, well, why were they doing that? It doesn't make sense to me. I'm like, yeah, it doesn't make sense to me either.
100%. I'm curious, do you have any one favorite patient story or one that really sticks out in your mind? Is just something unique happened, or?
Oh man, that's a good question. I'm grateful to say we have a lot, but I guess in terms of like, well, let's see, I could think of a lot of patient stories, but I think one of the things that keeps coming to my top of my head that I think covers a lot of these patients was, and not to sound like whatever, but man, for 21 years, we've been diagnosing upper cervical instability.
Yep.
And
my wife was one of those.
Yeah, exactly. Your wife. Yeah, I didn't want to say that due to HIPAA, but you can bring it up. And we had a lot of patients that for years were blown off, right? There's nothing wrong with you. It's you're making it up, you're malingering. And then we started doing, these tests to evaluate it. And the patients just cry not because they're happy they got it, but like, oh my God, this is what I've been telling people. So taking the time to find problems that other providers aren't taking the time to evaluate or evaluate properly has led to so many success stories. And then we've taken the time to publish some of those findings, where 22 years ago, the healthcare community has ridiculed us for looking at that stuff. Not all, and we still get some ridicule, but it's a lot less because of that work that us and others have done has now started to become a lot more recognized. And I think that in turn has led to a lot more patients getting the time and the treatment that they deserved, whereas before they were just blown off. And I'm not saying that it's all because of the work that we did, don't misunderstand. There's a lot of amazing providers that have been working with this, that we know, that we don't know, that have also been, but so I think with that is like, and then being able to find that and then help them and give them their life back is the reason that my wife and I still practice. It's that type of stuff where, it's trying to give hope to the people that were told they had no hope, or that give treatment for a problem that we know is there, where the last 7 providers have told them there is no real problem.
Yep.
And then they get their life back. Like, I think that, and we have luckily thousands of those stories, and it's like,
it's fun. It's fun being able to solve a problem that helps someone in a way that someone else couldn't.
And also I think just like, there's not, like, we've all heard this, and unless you've never been hurt or you've never had chronic pain, it's hard to understand. But the amount that pain and true spinal subluxations, that you and I can agree on what a subluxation is, how it robs someone's life and quality of life, it takes everything from you, you know, and being able to improve that or prevent it from getting worse is what I think one of the best parts of life is to live your life. And so many of these patients, man, their life from either a car crash or trauma or something else, you know, with what you do with scoliosis, a lot of them are born that way. It completely decreases their quality of life, and that robs you of your life. But if you can give it back and give them an increased quality of life, man, that's
and we see all kinds of things
ever.
as you do too. But like when I think about physical things going on in the body, I think I'd rather have a knee, a toe, a shoulder. Like the spine is the one thing I'm like, that's the one area like I want, like the last area I want a physical trauma to my body. That's what we deal with all day long.
Yeah, in the last place you want like a big surgery, you know, like I don't want a knee replacement, but or knee pain, like I don't want pain at all, but you know, fusions like for a spine.
I get people come see me as you do too that need those things because
they do.
But it's like that is like, but even the best surgeons will tell you, and they tell patients like, this is the last resort.
Totally.
We have it there if the best and appropriate conservative treatments have failed, then we can do surgery.
I'm super grateful for those surgeons that like, man, your cord is being compressed and we have to decompress it. And your cord is going to be healthier, but you're probably going to have chronic neck pain because we're fusing it. Like, it's not their fault. And I think that's the thing you hear a lot, like, oh, you know, spinal fusions fail, they have horrible outcomes. And you're like, well, yeah, but their spine was so damaged to begin with. And the same with us, like, look, your spine is really damaged. We're going to try to make it better. But just like with my spine, like, it may not be 100%. And like, hey, your cord's not, with the surgeons, your cord is not compressed. So, and now you have axial neck pain and other things that can follow. That's not a failure on the surgeons. That's just, man, this is what we were given, and now we're trying to, and then hopefully we can get like the work that you do with scoliosis, the work that we do with, you know, instabilities and kyphosis, as if we can make it better and prevent it from getting worse, there's less likely that you're going to need that surgery.
Absolutely. So as we're getting towards the end here, Evan, let's say there's a patient out there that's watching this, like, could you put it in words like, you may be a great patient for our practice if like this is what you're looking for or whatever, like how would you describe that?
One, if you don't know what the hell's wrong with you and you've been seeing providers, you just know you have pain, right? You want to come see us because we're going to try to figure out why you have pain and explain to you why you have pain. And not just like, oh, it's because your muscles are tight, or oh, you have a subluxation and you've been going and you're not getting better. Obviously, if you had a trauma, like you were in a crash and you're having issues, we can really evaluate why you have those problems. That's the type of patients that we like to see. Or, you know, on the flip side of that is, hey, I do get some stuff that's happening. Sometimes it comes, sometimes it goes away. Is, hey, you might be a great candidate where we can figure out what's wrong, and then we can cut it off at the pass before it gets bad, right? Like, I love the patients like, it's been getting kind of bad. Let's get it before you get that patient that's crawling in and you're like, oh man, your spine, like, how long has it been going on? Oh, like 25 years, right? And they haven't done anything, and you're like, whoa, your spine has made some really physiological changes from it breaking down, and that's going to be a lot harder. So yeah, our patients are like, you want to find out why you're getting headaches or neck and back pain coming and going, like, let's figure it out now. Or, hey, I've been trying to get this under control, I've been seeing people and they don't know what's wrong and I don't know what's wrong, and I'm in and out in 3 minutes or something like that.
And there's three things that I can say when I talk to patients, and also I get feedback. And you know, and my wife, I sent here to see you after she was in a crash, and I said, one, I know you're great at adjusting people manually, and you know what to adjust and what not to adjust to, and you know that's a skill in its own. Is you have to be great at actually understanding how to do good chiropractic adjustments. I know you're super intelligent and you're up to date as much as anyone out there on the science. And then three, you're going to give people detailed, focused care. You're going to take the time to really understand what's going on. but you're going to give them like just a great experience as well. They're not going to be rushed in and rushed out. And so I always feel really good knowing if someone comes here that they're going to get excellent treatment and they're going to get great care and have a good experience too.
Well, thanks, man.
So,
I feel the same
yeah.
about you, and I super appreciate that. And I know we've known each other for a long time, and that's why
I'm mostly lucky because you copied my haircut.
I know, man. I didn't have a choice, man. You know.
So if someone's watching this, like, how do they find you guys? Like, are you guys on social or what's your website?
We're at katzchiropractic.com. That's one way. I can't tell you what's on the website because I don't visit it very much. But you can go on. There are numbers on there. Obviously, we have something on Instagram and Facebook with Katz Chiropractic. You can just reach out and give us a call, and that's the best way.
Excellent. Well, thanks for being on the show.
Thanks for having me, man. It's so good to see you.
Yeah.
Yeah, awesome, man.